Hi, welcome back, everybody. It's also Vermont 211 Day today. So we have representatives from 211. I don't think we've ever actually like heard from anyone on this in this committee.
Yeah, well,
So really interested in hearing what you do. We did hear the other day about how there's sort of an integration now with 988 and 211 possibly happening to be able to route calls to the correct. So anyways,
I'll tell you all about it.
welcome.
Yes, thank you so
Introduce
much.
yourself and
Thanks for the opportunity to speak with you all. So I'm Allison Lamagna. I'm the Executive Director of the United Ways of Vermont and Vermont 211. A quick logistics thing is that I do have a few slides. So am I able to share my screen? Okay, why don't I just quickly do that so we can get that out of the way? Uh, okay, it's been a while since I've been on Zoom. Okay, great. So that's out of the way. Okay, so am here to talk about 211 and 211 Day and get to all of your important and great questions. I also want to just introduce, I'm joined today by Dr. Keith Robinson, who is the Vice Chair of Quality Improvement and Population Health at UVM Children's Hospital, among many other titles that we'll get to later. And I want to point out that also joining us is Kristen Fontaine from the Community Access Health Equity Program at UVM Health Network. Another United Ways colleague, Clarissa Francis here, and Beverly Boget, our supporters as well. So just wanted to acknowledge those folks in the room who may also be able to answer some of your questions. So let me start by giving you a little bit of background about 211. As you said, we are traditionally have been aligned with the House Committee on Human Services. So I don't believe we've had a lot of time with your committee in the past. We're here today to not only share about 211 Day and 211 services, but also to highlight some innovative initiatives that directly impact healthcare systems and community health outcomes. Today is the National 211 Day, observing and celebrating the 3-digit resource that helps millions of people across North America to connect to health. In Vermont, 211 provides free statewide access to community resources by phone, text, or a 24/7 online searchable database. And I do just want to say, I know we're not here to focus on budget matters, but before we launched into our sharing more about what we do in our closed loop initiative, I wanted to just note that a fully funded Vermont 211 is essential to keeping Vermont's information referral system strong. And thanks to the legislators' support last year, we were able to reach a sustainable funding level. And that has allowed us to really listen and evaluate to community needs and explore new impactful ways to expand support, like you'll hear about today. And there is a proposed decrease in the governor's budget this year to reduce our funding by $332,000, which would really directly impact our core services and thus limit our ability to advance initiatives like this closed loop referral that we'll share with you today. So we really need our level of funding consistent with fiscal year 26 in order to have our core services fully staffed and be able to respond to our highest call volume times and remain responsive to programs like the General Assistance Program and disaster recovery efforts and the rising needs that we're seeing as federal changes impact Vermont. So some background about us, our mission is to promote the health and well-being of all Vermonters through a statewide information and referral system that streamlines access to community resources. We are also nationally accredited. So we are an accredited information and referral program, and we serve as the centralized, trusted source of health and human service information for the state. We are, next one here. Oops. Essentially, we're like the front door to the complex systems of social supports that exist around the state to help people navigate what is best for them and what will meet their needs. We offer interpretation services for callers who speak other languages other than English. And we're also an integral partner in disaster response and recovery. We've supported the communities during going as far back as Tropical Storm Irene, the COVID-19 pandemic, and the flooding events of 2023 and 2024. Our database includes over 11,000 services, and it's constantly updated and vetted for accuracy. In 2025, we responded to more than 61,000 contacts from Vermonters across the state, and we're able to make over 22,000 referrals to those individuals. Our most requested referral is for housing, and we are sometimes known for our role with supporting the General Assistance Emergency Housing Program, but that is not all we do. We also connect people with services for utility support, tax preparation, public assistance, individual and family supports, disability services, programs for veterans, mental health. You mentioned 988, and we do have our relationship with 988 for a warm handoff. So if a caller that contacts 211 is having a mental health crisis, we can make that warm connection over to the emergency crisis services that they need. So one of the things that, when we are sustainably fully funded for our core services, it gives us the opportunity to look at exciting innovations and other things that we can do to support the community. And so what we wanted to talk a lot about with you today is an exciting new closed loop referral initiative. And this is something that we're seeing across the country. 211's partnering with health systems to address social factors that affect health and well-being. And we're very excited to be working with UVM Health Network to build a closed loop between Vermont 211's database and UVM's Epic system. This will strengthen coordination between healthcare and human services and ultimately improve outcomes for Vermonters. So I can pause if you have questions about 211 specifically, or we can continue on with our overview of the project.
Casey, I'm looking at your proposed budget cut and curious if that has anything to do with combining these services with 988. Are they supposing to pay for that portion with 988, or is there any? Can you explain what that cut means in terms of service delivery?
Sure, yeah. So, what it means for us is that the sustainable level of funding we need to perform our core duties, which is the expectation that we'll provide information and referral, that will support the general assistance program, that will be available in times of disaster. A cut like this would have us re-examine what we're able to provide out of that menu of things. We have done a lot of work talking with community partners, reaching out to the community, and looking at how we can best have an impact in the community. And our busiest time is between 4 p.m. and 10 p.m. in the evening. So we're looking at reducing some of the overnight time when we don't have the data to support the number of calls that come in and the costs that it is to maintain services for very few calls, and needing to instead staff up during 4 p.m. to 10 p.m. hour when we're getting inundated with calls, quite honestly, and also to be able to have the appropriate staffing levels for when crises happen. So for example, in November, when there was a threat to SNAP benefits, we see calls spike. When there's a change to the general assistance housing rules, we see calls spike. When there's a disaster, we see calls. And we need to be nimble to be able to respond to that. And historically, we just have not had the staffing levels that we need. So we're looking to support our busy times when we have an impact and think about our operational needs in that way. The cut, I think it comes because there's a misunderstanding that will somehow save us $332,000, which it will not.
Yeah, I think in the budget, it says that your hours are reduced.
Our hours that were open and available to the community may be reduced. We haven't actually determined what our hours will be going into the state's next fiscal year. They may be reduced, but that would be to bolster the times when we need support. We also remain available 7 days a week, 365 days a year, which means weekends, holidays, our online database, maintaining that 24/7, so people always have access to that. So our base level of service needs the sustainable funding in order to continue.
Leslie.
I'm just curious, two things, but similar to that question. What's your, what percent of your budget is 332?
Percent of our budget
What is your bottom line in your budget?
So our the level of funding we received in fiscal year 26 is $1,638,029. That's our,
That's that level funded,
Yes.
that's the same, so your total budget is 1.6 mil.
yes, that's the total amount of funding the state gives us, which is our primary source of funding for our core services. We do have other initiatives and we do seek funding in other ways to support community initiatives like the one we're going to share with you today.
Okay. So cutting, does the state, I don't, maybe you've been in contact with them and I don't think you know, but I don't know anyway, where they expect this to be covered. Do they expect it to be covered elsewhere?
I don't know.
They didn't have that kind of conversation?
No.
Okay.
No.
Thank you.
Sorry, we're trying to get our budget spreadsheet here. It's
Okay.
in a section of the budget we usually don't deal with.
Right.
Okay. Go ahead.
It's our section, it's our section, right? Who is it?
I think it's DCF.
Human
Okay.
Services.
Service.
Human services.
Okay, so we don't have any input. Unless we lobby them.
Yes, we'll go back.
Well, sir, need to understand my thinking.
Our contract is with Economic Services, because we also support the General Assistance Program, but that's actually a smaller portion of our core services. Yeah, thanks for your questions. Okay, so let me invite Keith to jump in the conversation here, and share more about our closed loop project, which I think this committee will actually be interested to hear more about. And again, Dr. Robinson is a pediatric pulmonologist, vice chair of quality improvement and population health at UVM Children's Hospital, medical director of clinical informatics and improvement science, and there's more.
There's more. I also work with the Vermont Child Health Improvement Program at UVM to do quality improvement and population health across the state with family medicine and primary care practices. So kind of have my hands on a lot of different population health and quality improvement projects to make sure that we're advancing the health of Vermonters. And this particular project is one really cool one because it kind of integrates the clinical side of things as a lung doctor, the population health perspective when we start thinking about social drivers of health, the informatics piece, because I build an electronic health record, so I build an Epic, like do some light programming in it to help improve the systems. And then looking at data. So this is kind of at the center of a lot of this. And having us think differently about how to deliver healthcare and think further upstream about how to help patients and families when they need to really think about their whole health. So this pictographic is really, all it's really showing you is that the care that we deliver in clinic and hospitals represents a very small relative portion to what actually comprises an overall patient's health. And I'm sure you guys all know this, right? It's the environment that we live in, it's tobacco use, it's housing, transportation, employment, other economic factors. So this is just a signal for all of us and our guiding light, our lighthouse, to say, as healthcare organizations, we need to think more holistically about where healthcare costs are coming from and how to think further upstream about how to mitigate those. That's why we started this work. We started specifically working with Kristen, who I can't say enough great things about, and the team of 50 plus people in the Children's Hospital that we've been meeting monthly for 6.5 years to address food insecurity in the Children's Hospital. That's now extended out into the rest of the medical center. So we're starting a food and medicine program that's picking up tomorrow afternoon. So this is really to try to address food insecurity. All of that work to address food insecurity comes down to a couple of things though. On the next slide, what ends up happening is we see a family in clinic or in the hospital. All of our clinics are screening, all of our inpatient units are screening for food insecurity and social drivers of health. The problem is this: we ask validated questions, we put them into electronic health records like Epic, which we spend a lot of money on. And then from there, we have to fax or place a phone call or give a number to a patient or family and then have them call 211 to go the distance to actually get connected to help. Healthcare organizations, we want to be screening for this. The issue is we don't have the resources and know about what's local to that patient or family in the community. 211 does. And so that's why for years we've been partnering to try to think differently about how do we deliver care, how do we form these community partnerships, and then how do we lean on our partners like 211 to make sure that we're actually addressing the upstream issues. So the current state, to be quite simple about it, it's inequitable because for healthcare organizations that are able to screen and that are able to provide resources to patients and families can provide a little bit better care than families that aren't in practices that are not supported with this automated referral. It's fragmented. Again, in 2026, the fact that we're relying on fax machines and phone calls instead of data systems is a little outdated, I think. So this is to try to get us further ahead into more data-driven world that we need to be living in. It's also confusing and burdensome, so we have to train everybody to figure out who do you call, when do you call, and then we don't actually really have visibility into what resources patients and families are connected to. So that leads to a lot of frustration from families to say, I already was connected to that resource, but we can't really tell because the data systems are not connected. So families are sitting in the middle with having needs, and we can't, they're not feeling like the systems are working for them and connecting them to the resources that they need. So, and then I also need to point out that the care teams are also very frustrated. So there's moral injury when we're screening for social drivers of health and not able to do something. We have an ethical principle. We don't screen for something unless we have interventions. And this sounds a little bit odd, but it challenges us to think differently about if you're going to screen, you have to have an intervention. So find out what that is. And for us, we've been, again, relying on 211 for this. Because our vision for this is to have universal access to screening and interventions, to have the data systems be integrated and talking to each other. This will allow us to be more efficient. It'll have us connected with IT systems. We'll be able to have more discrete data about confidential data around what patients need, what resources are working, and where do we need to make more investments in our community to support our patients and families. And then that will result in improved health. So what UVM Health did is we've gotten a grant that Kristen led from the medical center to fund an automated referral from Epic, the electronic health record, to 211 that will give confidential referrals to 211 and then information back into Epic. So we will know what resources patients have been connected to, what's working, what's not, and it'll allow more collaboration between us and 211. That will allow us to be better informed about what patients and families need, and then advocate for them, and then change how we invest dollars to help address upstream issues. So what we hope that this will result in is a better return on investment as it relates to how we connect patients and families to community resources. The collaboration, this is Vermont. Vermont is all about collaboration. It feels, this is one of those projects that I love working on, just because, I mean, honestly, this is what it's all about. It's about finding people in your community that have the same perspective on the importance of making sure that everybody in the community is happy, healthy, and has the resources that they need. This also addresses the upstream drivers. We can't keep doing what we've been doing, which is to not address food insecurity, to not address housing as it relates to healthcare. So we have to get in the mix more and think further upstream. We have to build trust between patients and families. We have to be data-driven. Again, in 2026, with AI coming on before fast and furious, we have to be data-driven to understand what our patients' families need. And then we think that this will improve care team wellness and also decrease healthcare costs. And then I'll let you.
Yeah, so with this, oh, sorry, go ahead.
Yeah.
I just had one question. So this is, this interface would rely on having Epic as your system?
Right now it would, for the dollars that we're spending. I also do, so I can speak to informatics, the IT systems a little bit because I do that at the health network. This connection could be available to other people, either that had Epic in the future, either FQHCs or others, or different EHRs around the state. I have worked a lot with other EHRs in the state to try to see how we can do different quality measures outside of Epic. So this could be, this is the first use case to say like this works, and then we could spread it to other clinics and hospitals. I've talked to other people nationally that are doing the exact same thing, and this is what is happening in the States. We used to be a leader in this space, and we're falling behind in terms of our connections. That's a great question, though.
What this looks like at 211, and I'll just add that this is 211's bread and butter. This is what we know how to do. We're experts. Our community resource specialists are nationally certified and trained to do this. So it takes the burden off of the healthcare providers and brings it to 211, where we have the know-how and we have the tools and the resources at our fingertips. So a referral would come in from the medical provider, and our resource specialists would be able to contact the individual and work with them to understand what their needs were, the need that they were referred to us for, but also to understand secondary needs. So up and through those conversations, we learn about secondary needs and we're able to connect with those resources as well. This would also allow our resource coordinators to do follow-up, a couple weeks later. How did that go for you? Were you able to connect? And then close the loop back to the medical provider.
And I mean, I think just to close too, this is one of those things that I really feel strongly, we won't be able to do our job in terms of thinking holistically about what patients' families need. And this program, in terms of our screening program and connecting 211, like really can't happen without 211. Like we, as healthcare organizations, we don't know what resources are out there in the community. And to have it built again would just be cost prohibitive and inefficient. And so if we're going to address health related social needs or social drivers of health in any healthcare setting, UVM health or not, everybody's going to lean on 211, I think, to make sure that we have, that's the central place where people would go to get resources, understand what people need. So I think this really helps us do our job.
And we're working to get connected to the statewide conversations about a statewide closed loop. We've had some preliminary conversations around that, but I really think there is a role for 211 in those conversations as well.
Leslie?
Yes.
So would this system require more staffing for you to be able to do? I'm thinking about this cut.
Yes. It likely would. And the other piece is that we have some outdated technology systems at 211 that are the base for all the services we provide. In order to upgrade those to be, to modern technology that can make the connections, the interface connections that we need to have with Epic and other systems, we need to sustain our funding so we can make improvements like that.
You're only asking for level funding here,
Correct.
but have you thought about, what the funding need? Pie in the sky, but if you were to implement this, what it would look like?
Well, the hope is that the health system will be supporting this in some way or another. This is, in the end, a service to them. But because it's replicable in other parts of the community and with other systems eventually in the future, that's in fact a way that 211 can be, less, but we can be finding funding in other ways so that our core services can be funded by the state, which, is the way, based on the expectations the state has of us, that makes sense, right? But then special projects like this can, we can diversify to find other funding streams for those kinds of things. But again, without the core funding, we don't have the capacity to do that. We're, stressed with staffing. We're trying to respond with limited resources. We don't have the technology systems that we need, et cetera. Is there more? That's
it?
We're going to leave more. Yeah.
From us.
Any other questions? Brian?
I mean, it sounds like 211 has evolved from being just a simple hotline you call, not to minimize it, but like a place you call to just get to like a more like holistic, strategic referral hub of sorts. And that it really has the potential with further investment to improve population health, because you're not just connecting people with a resource in the moment, but you're looking at other additional factors with them, you're tracking the data, et cetera. And that your funding request, it reflects that evolution.
Yes.
Okay.
Yes. Thank you
Yeah.
for
Yeah.
summarizing that.
So I want to make sure I'm understanding it all too,
I recently said to someone, this is not your grandma's 211.
You should have come up with that.
This is your great grandchild's 211.
We are part of the National 211 Network. And when I attend meetings with other National 211 leaders and hearing what's going on in other states, these are the kinds of things that are happening. And 211 is evolving and is poised and positioned. And we have the data, we have the expertise to be amplifying, the impact that we can have in communities in this way.
It appears, because we heard about global commitment dollars this morning, your global commitment investment. Well, I think that 332 is about 140, if I'm doing math in my head, 140 general fund. And federal match. All right, go ahead.
Since we have a few minutes, I might as well
Just a couple.
ask my perennial question of the year. You mentioned it in your testimony, which is how to say more about, or would please say more. Not can you, because you probably could, but please say more about the role artificial intelligence might play in improving population health when used in an ethical fashion through your plan.
Wow, that's a great question.
And the bells are ringing.
Yeah, right. So we use AI right now in clinical visits to record, essentially translate conversations and to put them into clinical notes.
Yeah, we heard about this, right?
Yeah, right. And so that's a really good power. I think the one thing I want to make sure of is that when we're using AI, it's got to be secure and it's got to be accurate. So as it relates to, we're talking about health related social needs and social drivers of health. I would be very careful around applying artificial intelligence in this particular situation without understanding exactly where the data is going to be stored, how it's going to be used, and how it can be error prone. These are things that you do not want to get wrong. There is no room for error to understand what a patient family needs in this regard. These are sensitive questions, and then sharing this data inappropriately is devastating. So I think as an AI case in regard to health-related social needs in this particular situation, I'm cautious at this point, and that's why I need to rely on the humans at 211 to make sure that I trust 211. And I think if you ask any other healthcare worker in the state of Vermont, they would say the exact same thing. I've talked to my friends up Franklin County on this too, and everybody relies on 211.
So it sounds like it might be a tool to make to improve the functioning of the system, but that it's always going to need a human review and human oversight.
I think so, because in my experience, like I've had patients that I've screened for food insecurity and they've screened negative. They've said, no, I don't have any issues. And I've known these families for years and I love them. And then eventually they will say, oh, I was embarrassed to tell you about this.
Yeah.
And so that just speaks to the deep personal implication of and shame of this. And so I don't think, sorry, I'm just concerned about reducing this to AI when it is such a human and very sensitive topic.
If I could add to that, I wanted
Did you
to.
say your name for the record?
I'm sorry, Clarissa French, thank you. And I'm a board chair of United Ways of Vermont. And we're lunch buddies, apparently. I don't know if you're I stood next to you or faith or whatever. It is not anymore. What I would like to point out is that 211 is open to AI being a tool for efficiency and productivity, especially because we manage complex systems. That said, it does take capacity to achieve the confidentiality and the rigorous testing that it would need to, and it takes that capacity to do that. To overemphasize the budget cut, but the budget cut, we're not asking for more, we're asking for what we were given last year so that we can continue to augment and answer questions like what you're getting to and utilize things appropriately.
And AI will never replace a human at 211. That's the whole point of 211. There's a warm person there to reduce that stigma, to help you, to help you discuss your needs, to do the follow-up questions.
But it can help the humans there help humans.
Yes.
Yeah.
Thank you. And thank you for coming in.
Thank you.
Thank you.